Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Vera Therapeutics.
For more than half a century, we've known what IgA nephropathy looks like under the microscope. Yet even today, about half of patients will reach kidney failure within 10 to 15 years. That gap between what we see on biopsy and what we can offer at the bedside is finally starting to narrow. As our understanding of IgAN pathophysiology deepens, new therapeutic strategies are emerging, including approaches that target the B-cell pathway itself. Hello, and welcome to the Renal Report, staying ahead of the curve on the B-cell pathway and autoimmune kidney diseases. I'm your host, Taryn Winter-Brill. In this special Medscape collaboration with KDIGO and the American Association of Kidney Patients, we'll connect IgAN pathophysiology and the latest updates from KDIGO to the emerging role of targeted B-cell modulators, including the lived patient experience. Today, we are at Stanford University in the heart of California's Palo Alto area, a region famous for its innovation and world-class universities. Our guest, Dr. Richard Lafayette, is the founder of the Stanford Glomerular Disease Center and a pioneer in IgA nephropathy research and care. He'll join us for a candid talk on IgA nephropathy and B-cell misfires, where we explore three key questions. What goes wrong along the B-cell pathway in IgAN? How do those immune misfires translate into kidney injury? And how can you recognize and diagnose IgAN in practice, despite the lack of active screening in the United States? Hi, Dr. Lafayette. Thank you so much for having us.
Well, thanks for making the trip.
It's our pleasure. Now, you've been at the forefront of clinical research in IgA nephropathy, or IgAN. So, in your own words, what exactly is IgAN?
IgA nephropathy is a pathologic diagnosis that carries grave risk of progressive kidney failure. It presents in multiple ways, but most often with blood and protein in the urine and mild to moderate kidney dysfunction. Most nephrologists are familiar with the classic 4-hit hypothesis of IgA nephropathy, and it's still a very useful framework. In simple terms, the first hit is excessive production of galactose-deficient IgA1. The second is a generation of IgG and sometimes IgA autoantibodies against that galactose-deficient IgA. The third is the formation of circulating immune complexes, and the fourth is the deposition of those complexes in the glomerular mesangium, which can lead to complement activation, inflammation, and ultimately kidney injury. The first hit is especially important. The IgA1 involved here is structurally distinct. It's missing terminal galactose residues at its hinge region. Genetics influence this O-galactosylation process, but galactose-deficient IgA1 alone is not enough to cause disease. Hit 2 is a key for moving from a relatively harmless aberrant state to one that causes cellular injury. IgG and IgA autoantibodies recognize the exposed galactose-deficient hinge region of IgA1 as a foreign neoepitope. And we know that some people have elevated galactose-deficient IgA1 in circulation for years or their whole life without any ill effects. So this immune recognition step is a crucial turning point. It's what pushes the pathophysiology toward tissue injury.
The 4-hit model describes what happens once the abnormal IgA system is already in motion and how kidney injury ultimately occurs in IgAN. But those 4 hits are really the downstream consequences of a problem that begins much earlier. To understand why the disease starts, we have to move upstream, back to the mucosal immune system and the B cell signals that set this process in motion. But if those 4 hits are the downstream effects, what's happening upstream that makes the B cell pathway so important?
That's where the disease truly begins. Patients, again, are genetically predisposed, and then something happens that triggers the immune system. It's usually a mucosal infection or another stressor along the gut or respiratory mucosa. In IgA nephropathy, the immune response becomes dysregulated in the mucosal-associated lymphoid tissue, or MALT. That's where B cells begin overproducing IgA and skew toward making galactose-deficient IgA1. So when we talk about going truly upstream, we're really talking about the signals that govern B cell maturation, survival, and class switching long before immune complexes ever deposit in the kidney.
So what are the signals governing B cell behavior?
2 of the most important are BAFF, or B cell activating factor, and APRIL, a proliferation-inducing ligand. Both are members of the TNF superfamily, and in IgA nephropathy, both are frequently elevated.
And how do you think about their role in the B cell pathway?
When I explain this, I often show the standard B cell maturation pathway from a primordial or undifferentiated B cell to a fully mature plasma cell making antibodies. Early in that journey, BAFF plays a major role in supporting maturing activated B cells, and as cells become mature, APRIL becomes increasingly important. Both BAFF and APRIL send signals through 3 main receptors. There is overlap in their expression and function, but generally, BAFF receptor keeps transitional B cells alive as they mature. TACI helps activated B cells class switch and become IgA secreting cells, especially in mucosal tissues. And BCMA supports long-lived plasma cells, allowing them to keep producing antibodies over time. In IgA nephropathy, that same system is activated to sustain the production of galactose-deficient IgA1.
In other words, BAFF and APRIL are not simple on and off switches. They help shape the entire B cell life cycle: which cells survive, which ones switch to IgA, and which plasma cells keep producing antibody over the long term. In IgAN, that biology may help sustain the abnormal IgA response at the center of the disease. And studies support this connection. BAFF and APRIL levels are elevated in the serum and mucosal tissues of patients with IgAN, and genetic studies have also implicated this pathway in disease susceptibility. Now, clinically, when we think about B cell modulating therapies that target BAFF and APRIL, how do you describe what they're doing, especially to colleagues who have concerns about broad immune suppression?
I describe them as targeted modulators of B cells. Anti-BAFF and APRIL approaches will reduce plasma cell activity because BAFF and APRIL are survival factors for mature B cells and plasma cells. And yes, you will see lower plasma cells and lower antibody levels overall. But one of the interesting aspects is that BAFF and APRIL are also pivotal for antigen recognition and class switching. By modulating those signals, these therapies are designed to blunt the initial over-response to mucosal stress that drives galactose-deficient IgA production while attempting to preserve broader immune function. And that's consistent with what we've seen so far in clinical studies to date. They haven't demonstrated large increases in infection rates, although ongoing evaluation of long-term safety remains important. Patients can still mount appropriate immune responses, but our goal is to reduce the pathologic ones that drive IgA nephropathy. That distinction matters enormously when counseling patients about what to expect, and we're still learning about vaccine responses with these therapies, but the early data is promising, and ongoing studies will help clarify this full picture.
Now, what strikes me is that there's no active screening program for IgAN. So how are these patients identified in practice?
Unfortunately, they're often identified opportunistically, which means late. A patient may feel unwell for a while, but more often a clinician notices high blood pressure, non-visible hematuria, proteinuria, or reduced kidney function on routine testing. The challenge is that those early abnormalities are missed or not followed up. diagnosis can be delayed until disease is more advanced.
And once IgAN is in the differential, what does the formal diagnosis require?
Diagnosis today still depends on a kidney biopsy. Clinical clues can raise our suspicion, but to make a definitive diagnosis, you need to see IgA-dominant mesangial deposits on a biopsy. Fortunately, the biopsy is also helpful in determining prognosis.
So even in this new era, IgAN is still mostly detected the old-fashioned way: blood pressure, urinalysis, kidney function testing, then biopsy to confirm the diagnosis. That makes clinical vigilance especially critical because without recognizing those early clues, patients may never reach the point of definitive diagnosis. So let's bring this full circle. How does the B-cell story we've been tracing shape the treatment landscape today?
I usually emphasize two broad concepts. First, supportive care remains essential. Blood pressure control, RAS blockade, and comprehensive risk factor management are still the foundation, and current guidelines anchor on them. But second, we now have options that act more specifically on pathogenic pathways, including the B-cell axis that we've been discussing. And what's important is that all these emerging approaches are built on the same arc: genetic susceptibility, mucosal triggers, B-cell dysregulation, galactose-deficient IgA, immune complex formation, and kidney injury. Understanding that arc is what helps us make sense of where targeted therapies will fit and why.
So who are the patients you're thinking about for B-cell modulating approaches, and when in the disease course?
Any patient with IgA nephropathy who's at significant risk for progression is a candidate for more intensive targeted therapy. That generally means patients with persistent proteinuria and any evidence of declining kidney function, as long as they're not at extremely low risk or already too far advanced. We don't yet have a clinical biomarker that tells us if a patient is especially BAFF or APRIL driven, so right now we rely on clinical indicators of progression risk rather than pathway-specific markers. But that's an area that's actively evolving.
So as we close, what are the key messages you hope clinicians will carry with them the next time they encounter a patient who may have IgAN?
First, IgA nephropathy is fundamentally a B-cell driven disease. The 4-hit hypothesis is a useful construct, but those hits are downstream of a process that starts with genetic susceptibility, mucosal triggers, dysregulated B-cell maturation mediated by signals including BAFF and APRIL. Second, because there's no active screening program presently, we have to be intentional about recognizing the early clues: higher blood pressure, hematuria, proteinuria, any declining kidney function, and then aggressively pursue biopsy to confirm the diagnosis.
The challenge in IgAN mirrors what we see across other autoimmune diseases. How do we reduce the pathogenic immune response without leaving the patient vulnerable to infection? B-cell modulating therapies are emerging that aim to target the misfires driving the disease, rather than broadly suppressing immune function. Understanding the B-cell pathway connects the biology of IgAN to the patients you see in practice and to the targeted therapies now beginning to reshape the field. On behalf of Medscape Education, I'm Taryn Winter-Brill. Thank you so much for joining us for this episode of The Renal Report, staying ahead of the curve on the B-cell pathway and autoimmune kidney diseases. Don't forget to complete the post-activity quiz and evaluation to receive credit. And we look forward to seeing you for our next episode, where we will explore the evolving role of targeted B-cell modulators in building evidence-based treatment pathways. Bye for now.